Hello and welcome to the second installment of the new STA clinic chat. This one is going to be centered around introduction to neurological assessments. So at the minute, we've just got Catherine on. I think we've got a few more registrations. So we'll probably have people jumping on as and when we go. So if people who are on could mute so it doesn't kind of jump around when we do the recordings. If anybody's got any questions throughout, Catherine, I know I'm only talking to you right now, just stick your hand up on Zoom and we'll get to it. Otherwise, I'll try and get through this as quick as possible. And then we'll go from there with questions at the end. So if you need me to slow down or anything, also just stick your hand up. Okay, so introduction to neurological chat. So I'm going to try and make this as concise as possible because I'm very aware that a lot of people have never done neurological assessment stuff, so I don't want to kind of go too above people's heads. So it's going to be a fair few things that we're going to cover. It's not going to be fully in depth, so when I say we're going to talk about the nervous system, it's going to be a quick overview. We're not going to do a full anatomy session and stuff like that. Just some indicators of why we do neurological assessment and then some techniques of what we do for neurological assessment. Okay, so quick breakdown of the neurological system, nervous system. So it goes to nervous system, which is obviously made up of your brain and your spinal cord. From there, it branches out to your peripheral nervous system, which goes to your afferent or sensory nervous system. Other branches for your motor nervous system, which includes muscles, obviously that kind of thing. Your autonomic nervous system, so that's things that we don't control, so heart, lungs, things like that. So we got somatic, sensory, I'll get my words out, sympathetic nervous system and parasympathetic nervous system. I've been putting this together and I said nervous system so many times today, so if I get it wrong, that's why. Okay, so main things we're going to be kind of covering for the assessment stuff today. 4 plexus, so 4 different plexus. So we've got cervical, brachial, lumbar, sacral, kind of rocked in as 2, rocked in as 1 together. So your cervical plexus obviously originates at cervical spine number 1 down to number 5, depending on literature you read. This supplies head, neck, shoulders. It has sensory input from C2 to C4, C1, C0. C1 at the top doesn't have a sensory. And then the motor branches are C1 to C5. And then there's a little bit of crossover with brachial plexus at C5. C5 down to T1. As you can see on screen there, it kind of branches out into various trunks, divisions, cords, and ultimately ends in shoulder, arm, and hands, which is kind of your peripheral from your brachial plexus. Moving down to lumbar sacral. So once again, depending on the literature you read, lumbar plexus starts at T12 and goes down to L4. Some literature says L1. Sacral plexus starts at L4, so slight crossover at level there, down to S4. The anterior branches from the lumbar sacral plexus supply the flexor aspect of your legs, so hips, quads, and then the posterior branches supply the extensors and adductors. So that's quite important when we get onto like the assessment bit, so you know where you're kind of assessing and what you're assessing. So obviously you've done your subjective assessment bit, and that's why you're moving on to the more objective type stuff. So you may have done your active and passive movements, your strength testing and stuff like that, or you may have chose to go straight into neurological assessment, depending on what you found in the subjective. So some common things to kind of look out for and listen out for when you're actually talking to your clients. So shooting pains. So if it's a shooting pain, if it's quite diffuse pain. So generally, if so, we'll stick to kind of hamstring and lower leg. If somebody tears a hamstring, you feel the pain where the tear site is. A radicular pain tends to be a little bit more diffuse and kind of spans across the length of the limb. So generally, soft tissue damage, you can kind of put one or two things on where the tear site is. Radicular pain is a little bit more difficult to locate. A radiculopathy, that tends to be more your altered sensations, pins and needles, numbness, and weakness. This tends to come more from central nervous system, so spinal cord, brain type injuries or kind of causes. And we got, like we just said, localized or mechanical. This can also be localized or mechanical pain at a spinal level. So you know, your spine has ligaments, it has tendons and muscles. If you injure one of those, it can cause inflammation and swelling, which may then give a kind of neurological or referred or a radicular type symptom. And then referred pain. So everyone knows referred pain from kind of trigger points and stuff like that, but it can also come from internal organs. So, so your gut can refer pain backwards towards your spine or towards different parts of limbs, depending on the neural pathway. So these are the kind of things that you'd be looking out for in your subjective assessment. Kind of go, maybe I need to look a little bit deeper than just a little bit of active and passive and strength. Doesn't want to go down 2 seconds. Where are we at? There we go. So a couple of things to be aware of when you are assessing. Some things are kind of obviously going to be outside of scope. So neuropathies, so sensory, so that's things where it's going to be altered sensation, different sensations, pins and needles, numbness, that kind of thing. Then you've got neuropathies affecting motor, so that's going to be strength and how you move. Autonomic, so that's more your organs and things you don't control consciously. And then moving on to kind of different types of neuropathy. So you've got a mononeuropathy, which tends to affect one single nerve. So things like Bell's palsy, where you get kind of dropping of the face, drop foot, that kind of thing. So it's more of a weakness type thing. A mononeuritis, which will affect several nerves in the same sort of area, or a polyneuropathy, which tends to affect all of the nerves in the system. A couple of other things to look over, which obviously we need to be aware of when we are screening for neural. So one of the big ones, which everybody kind of has heard of, is corner equina. So things you tend to be looking for there: incontinence, bowel movements issues, so if they can't control bladder and bowel, weakness bilaterally. So unable to stand, bilateral weakness, and bilateral shooting pains, those kind of things. If people are getting those kind of things and excruciating back pain, send them straight away. From reading literature, there's about 48-hour window from onset where that will probably need addressing. So send them straight to A&E, get them away as quick as possible. Thoracic outlet syndrome. Seen a few cases of this, tend to be more common in women. The ones I've seen have been, how should we put it, well endowed ladies, so they're kind of a little bit more forward. And I've also had people come to me say they've been diagnosed with thoracic outlet syndrome historically, but it can have a vascular and neurological nature, and the symptoms vary a fair bit between the two. And also the treatment will vary a little bit between the two. And then, as we mentioned earlier on, things to kind of look out for: red flags, including peripheral pathologies and visceral conditions. So if something doesn't quite sit right with you, just move them on. Just move them on straight away. It's not worth kind of going and ahhing about and, you know, if they're in good enough health, you can continue your session and what have you. But if anything is kind of screaming out to you is not ringing true, just send them straight on. Yeah, and it doesn't want to scroll again. There we go. So a couple of things which I have to hand if I know I'm doing one. First thing I did was make a form. This is a snippet of a form because there's a lot to remember. And I have a memory like a sieve. So I have to have basically prompts there to remind me what I'm doing. So I'll get onto that in a minute. A couple of useful things to have, tissue paper or cotton wool. A reflex hammer, if you've got one. There's a couple of different variations. I have one of those. It's solid metal. It's got a point on one end. I don't actually use that one a lot. The main bit I use is the pointy end. But you can use these ones, which are long and flexible. These also have a point on, but it's not the same because it's plastic. I actually, for doing reflex testing and stuff, I prefer that one. For a quick check of stuff, I use a handheld dynamometer because I can get a good reading very, very quickly. If somebody's kind of lost grip strength, I can get a good reading straight away. I've also got an active force, which I can link up to my phone, so to get kind of more objective baseline measures for stuff. But if somebody's got a serious neurological condition, you're going to pick it up. And one thing I don't use very much for this kind of stuff, but is useful to have, is a tuning fork. They're about £5, quite handy to have. So I made this form. It's basically got dermatomes on just to the side of this. There's also a dermatome map to kind of give me kind of prompts and reminders of what is where. The thing with dermatomes, which I'll get onto in a minute, it's not an exact science. It's also got a list of myotomes and their final levels on their movements, neural tension tests and what they're actually testing or biasing, shall I say, and reflexes, the main reflexes that I kind of cover myself. Okay, so getting on to dermatomes. So most people have heard of dermatomes. Slight difference between dermatomes and cutaneous nerve function. So a dermatome is a strip of skin which is supplied by a single nerve root. Cutaneous nerve is supplied by a single nerve. So it's the actual nerve. So this comes from a specific nerve pathway. So C1, C2, C3, all the way down. The other one is from the branch, which has come from that nerve root. And it's part of the afferent sensory system. So obviously you feel touch, which we interact with on a daily basis as therapists. So it's quite important to know what you're kind of doing with the dermatomes part of it in general, I think, because you can pick things up while you're just treating people as well. Few things to look out for when you're questioning at the very, very beginning. Some more things to kind of look out for, keywords, triggers, and also what we are going to be assessing when we do the dermatome assessment. So anesthesia, which is loss of sensation. So that's your numbness. So when somebody, the outside of my thigh feels numb, it doesn't feel right. Lost sensation in hands, that kind of thing. Paresthesia, which is more radiating, shooting pains, in the words that you start to associate with nerve pain themselves. So itchy, burning, pins and needles, skin crawling, that kind of thing. And then we've got hyperesthesia. I probably murdered that word, which is increased sensitivity to touch. So things like in your assessment, your subjective assessment, when I put my t-shirt on, it hurts. The rubbing hurts. It feels horrible to, that kind of thing. And these are the kind of things we want to pick up on and assess with the dermatome assessment. And what we do is we go back to that form. This is my old version of the form. So what I've got on this is I give a little mark. So if the dermatome on the left-hand side at C2, was had a increased touch response, I'd give a little mark. So it gets a score of 1, it gets a 1 or 0, and I kind of add up. But what I use these for generally is kind of go, right, well, there was a response at C2, C3, right, okay, mark that. And then I use that going forward. So I don't use that as much the definite tool. Go, right, it's definitely C2, C3. It's about painting your picture as you go along, which I'll get onto as we go through. Okay. So things, obviously, your sensory nervous system is stimulated by various sensors. Main ones being touch or pressure, pain. So that's your sharp blunt, which is what I use that for. So it's a sharp end and it's a blunt end. So I can just do it both at the same time. If you haven't got that, pair of scissors, just be careful. I've also used pen tops, the little bit off a pen top. Something that is sharp. So, but obviously you need to kind of do this away from them seeing. Hot and cold, if you've got the facilities to do so, and vibration. So with the touch one, you can use your hands, light touch with your hands, but what you get with that is you've got the heat from your hands and you've got the actual touch. So you obviously people respond differently to human touch as to what they do. So I tend to get some blue roll or some tissue paper, the couch roll, ball it up, and I stroke across the skin. I try to stick as much to the kind of dermatome pattern as possible, but sometimes I kind of just straight across, straight down. I try to do it on bare skin if possible. Obviously, in certain situations, that is not possible. And I do it in smaller strokes. But rather than going full length of a limb, I'll do it in smaller strokes. And I do it right to left, left to right, whichever way, and compare. So if I do it both at the same time, it can confuse them and they go, oh, I don't know. If you do it straight after the other, left, right, does that feel the same or different? Feels differently. How does it feel different? Increased sensation or diminished sensation? If it's increased and it feels sore, then that's a positive test for that. But at the same time, if they can't feel it, that's also a positive test. So you need to note what the response is. So pain response, I don't like to use that word pain for this. It's more a painful stimulus. It's a bit of a strange word to use, I suppose, because you don't want to cause them pain. It's literally there, right? Can you feel that? Can you feel a point? Can you differentiate between a sharp and a blunt? So it's light pressure at various points across the limb. So if you do an upper limb and somebody's got radiating pain down all the way down their arm, start proximally and work distally. Obviously around here, there's a lot of nervous tissue, so your brachial plexus originates from here. You don't want to be just jabbing things in. So you need to be careful where you're pressing. Because if you hit a nerve point here and cause pain, you've lost their confidence straight away. So it's about being kind of firm but gentle to get a response from them. I tend to get them to either look up or look away as well. And get them to close their eyes. If they're struggling to relax, you can have them lying down and doing it, and just get them to lie down and close their eyes so they're a little bit more relaxed. Once again, compare bilaterally. And is it an increased sensation or a diminished sensation? I tend to do it in this order as well. So the touch first because it's a little less invasive. And then the pain, the pressure, sharp, blunt. Hot, cold. We use various different methods for this. I've got 2 test tubes. Fill one with ice, stick it in a cup of cold water. I've got one filled with warm water, filled with a cup of warm water, and you can do it that way. You can also use metal spoons in warm water, not hot water. So if you've ever burnt yourself with a teaspoon to making a cup of tea or coffee, it's not nice. You don't want to be doing that to somebody. Exactly the same principle. And they detect hot and cold. They need to be looking away for this bit. So they need to not know what you're putting on, because it's about if they can detect the sensation. Same again, compare bilaterally. find whereabouts it is, mark it down, make a note of the rough nerve route, if it's down the back of the arm, if it's hand, if it's back of shoulder, across clavicles, if it's lower leg, is it toes, feet, that kind of thing. Trace it back to your nerve routes. Vibration, exactly the same thing. I tend to just tap this on the corner of my desk, vibrates, you put it on. Can they feel that vibration? Can they feel a vibration? And does that vibration cause an increased response? If it causes an increased pain response, it may indicate something as well. I tend to use those more for kind of checking against stress fractures and things like that. I'll be honest, I don't use that very much for this kind of testing, just because I haven't felt the need to. Okay, so myotomes, same sort of thing. So the dermatomes is the skin supply of nerves. Myotomes is a group of muscles which is innervated by a single spine root. The literature varies massively on this about what nerve root supplies what. So when you're doing a myotomal test, what you're actually testing. So when I've come to the next part in a moment, I've kind of done it's a whole encompassing one. When I go back to mine, I'll explain the ones that I've done because it just simplifies it for me. But you can kind of go away, do your own research and choose which ones you want to do. But ease of use for this, you can use the Oxford scale. So 0 to 5, 0, no contraction, 1, little bit of contraction, you can feel a flutter, 2, movement through with gravity eliminated, so that would be sideline if it's a knee, against gravity only, so they can straighten out the leg, once again with a knee. If we're sticking with knee, against gravity and some resistance, whatever subjectively, objectively, some resistance adds up to. And then 5, full power. So you can do that through a range isometrically. I tend to do it isometric because it's quick. So if I'm doing this kind of myotomal testing, you can do it quite quickly, moving from one to the other if you get a little routine going. Same again, if I want to test strength, you can use dynamometer very, very quickly if you're testing upper limb. Okay, so the myotomes of the upper limb. So you may have already gone through some of these movements if you've already done part of your objective. So if they've got neck pain or got shoulder pain, you may have already got them moving through some of this. So you might already know they can do it. So I tend to get them to do it actively themselves before I apply any resistance. I've never come across a case where I've had to do this laid down because if I have to have them laid down to do a resistive test, they're probably not, I'm probably pushing them too hard already. So if you work down this list, it's quite easy to come up with a very quick routine. You can stand next to your client, behind your client, and check these movements very, very quickly. So cervical flexion, hand on front of head, can they push into that? Cervical extension, can they push into your hand? Okay, lateral flexion, one hand on one side, one hand on the other. If they can resist it and they've got some, and they're not allowing you to move, you get a score, it's fine. Shoulder elevation, you can do that both at the same time, hands on shoulders, resist that. Shoulder abduction, resistance there. Elbow flexion, can't see my elbows on the screen. And then this is where it starts to get a little bit kind of right, it's this one. I tend to go elbow flexion straight into elbow extension because that's just where I'm at. So I go elbow flexion, elbow extension, push down. And then you've got wrist extension, wrist flexion, and then you've got finger extension. So literally do these tests. So just push on one. I tend to just choose one. If they can do that, they're fine. You can do it in an extreme movement. I'll get my screen right. There we go. And then finger abduction. So try to squeeze fingers together, or can they squeeze your fingers? So it's finger abduction, finger adduction. So do that, squeeze, put your hand in between theirs. Can they squeeze your fingers? You can do that very, very quickly. So flexion, extension, lateral flexion, shoulder elevation, abduction, elbow flexion, extension, wrist flexion, finger extension, finger flexion, finger abduction. Straight there in front of you. That's your biotomes done straight there. However, if you find something in between and you are testing left to right, and I prefer to do it both at the same time, because especially with like things like elbow flexion and stuff like that, you will find one will give way. And once again, that is not to go, right, it's definitely that, because it might have a bicep injury. But if you've already found a C5 dermatome, and now you're finding a C5 myotome, you kind of go, right, okay, around C5, C6. So I'm starting to paint a picture of where this may be coming from. So maybe neurological. And then you've got your lower limbs. You can do exactly the same sort of thing with this. So I sometimes get them just sat on the edge, so because you can do it there, or you can get them laid down if it's more comfortable for them. So they can lay down and you can kind of go through this way. So hip flexion. I sit on the edge of my bed. I think I put the brakes on, so if I go flying, I apologize. Resist hip flexion, knee extension in that way. So just literally put my hand in there. So knee extension, dorsiflexion, and inversion. And then you get onto big toe. So try to push the big toe down. And then knee flexion, hip extension, but knee flexion will suffice for that, and plantar flexion. There's a bit of crossover around S1 in the literature. So I tend to use knee flexion for S1, knee flexion and eversion, and plantar flexion for S2. So, but once again, you can have them just seated on the edge of a bed, nice and comfortable, run straight through it. But you'll have already screened for some of this stuff already. If you've got any questions about this, and I'm going too fast, by the way, just shout up, okay? So on to the next bit. So deep tendon reflexes. So these can actually be quite tricky to do if you've never done them before. Knee one tends to be a little bit easier. I can do bicep okay. Ankle one, I find a little bit more challenging at times, but that's why I prefer this, because you can get a little bit more rhythm going with it, and it's a little bit more flexible rather than you having to hit. So the point of this is to test the integrity of the central and the peripheral nervous system, because when you're hitting, you are creating a response from it sends a signal back to the spine, which sends a reflex muscle contraction to the muscle. So for instance, if I'm testing patella tap on the patella tendon, I hit the patella tendon, sends a signal back to my spine, which then sends a signal back, contract my quadriceps. That's why you get the kick out, and it's involuntary. The key to doing what I've found with doing tendon reflexes is getting them to relax and maybe concentrate on something else. Because what happens is, if they know you're about to hit them in the knee, they tense up and they're expecting it, so they don't do it. So you need to get them to relax. So what I tend to do is kind of get them, to put them like this, or I do this, I get them to do something, which is, right, I want you to squeeze your hands together as hard as you can. I want you to pull that, or I get them to count back at the same time. Right, pull that and count back from 10, and then I'll do it. Because to concentrate on that, so they're not kind of tensing up the quads to give me possibly a false reading. But like I said there, the tapping aims to produce an involuntary contraction of the muscles. The tendons need to be on a slight stretch or have some pressure applied. So knee in slight flexion, either in slight flexion, I tend to do it over the side of the bed, so in 90 degrees, but you can do them in supine with the knee kind of in a slight bit of flexion and use support, so their knee is over the top of your arm. So they're in just a little bit of flexion. If you're doing bicep, we'll get onto it in a minute, you need to put pressure on the tendon, because if you just hit the tendon there, you're not going to find anything. It's quite difficult to hit the tendon where you need it to be. Whereas if you do it on top of your thumb, And what we're looking for is diminished and brisk responses. So there is a grading system on this. So the grading system is 0 to +4. +4. So when I go back to my sheet, I've got little boxes and I grade them and I put it on, so I now make a note of it. So what you're looking for, so +4 is a very brisk, hyperactive or clonus. The clonus is where it twitches like this. So that's obviously my hand doing it, but people getting feet, I've seen a clonus response once years and years ago in a foot, forced plantar flexion, forced dorsiflexion, and it had a clonus response and it just started trembling. And that's an involuntary response. So you're looking for, if we're going for a knee, you're looking for excessive kick out. So you're only looking for a little jerk. We're testing both sides. Test the good one first, then test the bad one. Okay, so technically, in theory, the good one should have what is their normal response. And then the bad one should have, if it's coming from, if the injury is to that side, it's the nerve root on that side, it should be more that side, but you can get a bit of crossover. So 4 is a very brisk, hyperactive clonus. +3 is what is described as brisk or slightly hyperactive. You know, once again, quite subjective. So what is my slightly hyperactive might be somebody's, when they're testing, maybe they're normal. So it's what you perceive as well as a therapist. But once again, it's about painting a picture. So it's as you're going through your procedures. 2 is normal. 1 is diminished or sluggish. So that's where you're struggling to get a response. Well, you will get it, but it might just be a little, or it takes its time. So you get it, you hit it, and then it happens. So I have seen those in the past. 0 is no response. However, I've had no response, probably because I wasn't doing it right as well. So you need to be aware that if you're not doing it right, you are not going to get a response. And what you're going to use these for is it kind of indicates where, so that grading system will indicate whereabouts the issues may lie. So decreased, diminished, or no response may kind of indicate something with the peripheral nervous system. But obviously, if they're getting no response, it may indicate something with the central nervous system as well. So it's indicating. And then an increased response. So if it's the clonus and the really hyperactive movement, that's indicating more central nervous system. If you're getting clonus, it's indicating pathologies. So we need to get them probably moved on for further investigation. Okay, so a couple of ways of doing these. So I'm keeping these, I'm not going through every single one because there's a lot of them. I'm going through the main ones I've used historically. So C5, C6, bicep tendon. So what you do is, on the patient, you get them slightly relaxed. I tend to support their arm on a pillow. So they're in this position. And I place my thumb, so you find the distal aspect of the tendon. So it's proximal to its insertion. So I tend to go here, just above, can you see that? Just above its insertion point. If you're struggling to find it, put your thumb on and then supinate and pronate. You will feel it moving. If you're in this, you want them in slight flex position, get them to move, and you will feel the tendon. You're going to put a fair bit of tension on that. And what you do is, I'm going backwards, you strike the top of your thumb. You strike the nail of your thumb while you're applying pressure. You will feel, if it's a response, you will feel it contract underneath your thumb. So rather than just hitting the tendon directly, it's transferring the force through your thumb. So it's just a bit of a more gentler way of doing it. Tricep, there's a few ways of doing this. I found this picture eventually, because this is the way I've found works best for me. So I tend to have arm up here I support the arm. So obviously I'm a client at the moment. So I will support the arm as much as I can. So this isn't contracted. So I want that to be as relaxed as possible. And you're aiming to hit just proximal to the olecranon, which is why you need them quite relaxed. Be aware as well, there is ulnar nerve and stuff around here as well. When I was practicing years ago, I did get hit on the ulnar nerve and it sent a shooting pain all the way down to my little finger and hurt for days. So do be careful. Once again, you can use fingers over the top. It's not as easy to do. But I found that position because you can get it in a good stretch and you try and get them relaxed. People also do it in this position, but I find I can't get them to relax as much because they're wanting to support their shoulder themselves. So that's C6, C7. So once again, we're looking at the nerve roots for each of these and painting a picture of what we've got so far. So where was the dermatome? What was the weaknesses in the myotomes, if there was, and how are the kind of reflexes from that nerve root happening as well. Knee jerk. So like I said, a couple of different positions you can do this. Edge of the bed, knees at 90 degrees, strike in the middle. You're looking for, so if that's your patella tendon, if that's your patella, that's your tuberosity, aiming for the soft bit in the middle. Okay, so aim for that, and you're looking for the contraction and the kick out. You can do it in that way, or you can, she's got on the picture there, she's holding the limb there. I tend to thread my arm through, put my arm on their opposite thigh, so their leg is on here, and then raise up a little bit and do it that way, just so I can get them to relax a little bit more. I prefer to do the seated version. Medial hamstrings. This one's a bit more difficult to do, especially on kind of larger people. When I say large people, I mean kind of more people with a bit more subcutaneous fat, because you have to get to the tendon behind there, and sometimes it's kind of hidden a little bit. Tend to do this in prone position, because then you can see you've got a bit more control over the lower limb, so you can control that and take full weight of that while you strike the tendons, and you're looking for exactly the same response. Achilles or ankle jerk. A couple of ways of doing this. I prefer to do it with them in prone, with their foot over the edge of the bed, so I can kind of feel contraction from my hand as well. So if I'm struggling to get one, I may put a little bit of overpressure with my hand just to get a little bit more stretch on it, and you're striking just proximally to the calcaneal insertion, so kind of a few centimeters just above. So you want the fleshy part, because it needs to hit the tendon to create a contraction, to create a shortening, to create a reflex shortening. Okay. Other ways you can do it: get them sat up on the bed, bring their foot and their ankle outwards, and then strike from the top. The thing is, with that, you have to go underneath. You can do it side lying, however, it's about learning what works best for you. The key to doing tendon reflexes is practice massively, because they are quite, when you first do them, they are quite difficult to do. Some of them, I found this one really difficult myself to do. This one in triceps was my worst one. And then another one, the Babinski sign. Some people may have come across this already. So this one is quite an important one to do if you're starting to kind of go, right, there's something not right here. If somebody has a positive Babinski sign, you probably want to send them straight off to further investigation, really. So what we do is, that's where this one comes in handy. You can use your finger, but I tend to use the point of this reflex hammer, and then you trace up from the heel down the lateral aspect, up towards the toes and across. What you're looking for is the toes to curl. So if people have got ticklish feet, their toes will curl straight away. Some people kind of don't really have ticklish feet, so they don't really respond to it. So they might get a little bit of movement. However, if the big toe goes up, and so it starts to extend and the toes start to splay out, that is a positive sign. That positive sign may indicate something a little bit more sinister going on, motor neuron lesions, hemorrhaging, tumor at spinal or brain level, because the signal isn't processing properly, so it's creating an alternate response. So that's quite a handy one to have in your toolbox. So although it's not the same kind of deep tendon reflexes, you're kind of hitting something, it's a reflex as such. Probably should have labeled that slightly different. Have you got any questions at the moment? Okay. The next bit, so we're going on to more kind of movement-based stuff again. So we've gone through your dermatomes. So a lot of these are kind of a little bit more centrally kind of based, you know, nerve root kind of thing. So you're trying to, right, what nerve root are we looking for? So by painting your picture down, right, okay. So now you've got an idea of where you want to be testing. Because in my experience, these next tests can be quite provocative. So I tend to do these last myself personally, because they can, if I do this first and get a response, everything else is quite possibly going to be a little bit more, it's going to be more positive. So they may get like false positives because I've irritated something. So these are aimed at assessing the mobility and length of the neural tissue from where it leaves the spine down to the tip. So if it's upper limb, so it's from your spine, from your C-spine, down to your fingers, your thumb, little finger, whichever one, whichever nerve you're testing. And the idea is to add a progressive tension along that neural pathway to see where the restriction or the compression may lie. So once again, I always test good side to bad side, because some people just are just quite tight. You know, they just got, they may just have neural compression in upper limb, but it's asymptomatic. So if you do the bad one first, and you go, oh, that's it, it might just be their normal response. So you need to kind of be aware of that. And also try to do these in the same order each time, because you're tensioning the tissue in a sequence. So if you do it in a slightly different sequence, you may alter the result going forward. And obviously, if you're doing a test retest kind of thing over a number of weeks, however long, you need to be able to reproduce what you're actually doing. So there is 4 main upper limb neural tension tests. So called upper limb tension tests, ULTT, and they're really weirdly numbered. I actually don't know why. So this one is upper limb tension test 1. And this is to bias, not to test, it's to bias the median nerve. So all these shoulder ones that we're about to go through all start with, excuse me, shoulder girdle depression. So on the picture here, the guy is literally pulling down, so they're in supine position with their shoulder up against the edge of the couch, and they're going to passively depress the shoulder girdle. So you add on and you keep that on. So you need to maintain these movements throughout. So the median nerve, it's shoulder girdle depression, and then joint abduction, so with a straight arm, forearm supination, then wrist and finger extension. So at this point, you're holding onto their hand and you are bending their hand backwards in a supinated position. And then you externally or laterally rotate the shoulder. Okay. And then you can move the elbow through its full range into extension. Okay. So where you're ending up is over here. Can't see it very well on there. So if they don't get any response from that, while they're in that position, get them to flex their cervical spine away. If that brings on symptoms, you are adding on an increased tension. If they move their head towards and it brings pain away or reduces the pain or symptoms, then you may say coming from a little bit more of a nerve root. Similarly, if they get symptom throughout any of that, you can move towards. If it diminishes it, it may indicate a positive test further down. Like basically, what you're doing is tensioning from one end to the other. So I'm tensioning it from one end peripherally. As I relax it from that end, in theory, it's relaxing and allowing a little bit of slack peripherally. If I then move it back here and it brings it on, that means it's tensioning from this. So it's between, and that's why it's important to do each of these movements, because you might find their symptoms are reproduced at stage number 3, which is forearm supination. So you don't want to kind of go, oh, actually, so you want to keep it in the same pattern, because then it's tensioning it in the same way every single time you do it, as close to the same way what you can do it. Next one is median nerve again. So start with shoulder girdle depression, elbow extension, lateral rotation of the whole arm. You're in that position. Wrist, finger, thumb extension. So I tend to put my hand in theirs, move back. Abduction, and then you use your differentiation again from your cervical spine. So it's pretty much the same thing, but this is called upper limb tension test 2A. And the reason it's called 2A, because there's a 2B, but there's no 1A and 1B. So 2B is for radial nerve bias. Once again, start with shoulder girdle depression, elbow extension, medial rotation of the arm, wrist and finger and thumb flexion. So you're going the opposite way. So if you think of where your radius is, going down here, so what you're doing is you're stretching and moving it away. So you're trying to elongate that radial nerve, and then you're going to move into abduction. So we are tensioning it from there, and then moving away. So the idea is the two ends move further away. We use exactly the same thing if we need to, with the lateral cervical flexion to and away and towards, to differentiate between if it's coming from the nerve root. Generally, if it is coming from up here, you tend to get it a bit earlier, to be honest, in my experience. And then we've got ulnar nerve, upper limb tension test 3. So this will be, you can use these as well as a little bit of an exercise, which I'll kind of get onto as well at the end. So this one is shoulder girdle depression, abduction, lateral rotation, so into that position, elbow flexion, so they're now in a surrender position. So I'll go through that again. Shoulder girdle depression, abduction, lateral rotation, elbow flexion, forearm pronation. So you're now in that position. So your hand is, that's it. So your hand is facing away. Wrist and finger extension. So you're now in that position. And then you abduct until you get up to here. What you're looking for is a reproduction of their symptoms. So as I do that, I can feel all the way down there, all the way down there, and into my little finger. But I get that on both sides. So that's normal for me. When we're in that position, if it hurts more doing that, is it released by doing that? So that's quite an easy one to do yourself as well. These are exactly the same thing, lower limb. So the idea is exactly the same. We are tensioning neural tissue. So one everybody's generally heard of, straight leg raise, which biases the sciatic nerve. The idea behind this is to kind of differentiate between where the compression or the disruption is coming from. So in the first kind of 35 degrees-ish, it's quite slack, so they should be able to move up, so there shouldn't be any kind of compression. At 35 degrees, that's where there's more pressure on the lumbar discs. So if you start to get it at 35 degrees, it indicates that there is more of a likelihood that the tension is coming from that kind of point there. So from the actual disc or the nerve root itself. As you move through that range, the disc doesn't really change anymore, so it shouldn't really affect anymore. So if you're not getting anything up towards kind of 75 degrees and you get something over 75 degrees, then it's not generally to do with the spine as such. And there's a few ways you can do this. Supine with head supported, because you want them in a neutral cervical spine as much as possible. I tend to get them to do it actively, briefly first, just so I know roughly where their range is. Because I don't want to be kind of pushing up and causing them some pain. So I always like to get, like with this one, the upper limb ones are a little bit more, right, when you do this, and do this. You can do it, but it's a little bit more complicated. This one's dead easy, right? Lift your leg up as high as you can. Grasp from the ankle, because you want weight of the full limb, and you actually want to keep their knee fully extended. So we lift up into hip flexion and keep going until you reproduce their symptoms, or you feel, it's not going to go any further because of muscular tightness, just anatomical, that kind of thing. If they do get a symptom, so you get towards like, I don't know, 50 degrees-ish, 60 degrees, and you get a bit of symptoms, what I do at this point is I drop off a couple of degrees until it's just about there, and I will get them to tuck their chin in. Does that bring on the symptoms? So we're now tensioning the nerve from both ends. If that doesn't, I will take it back to the biting point where they're feeling the symptoms at 60 degrees, and I'll get them to do it again. That increases it. It's indicating that it's obviously kind of, it's coming from further up than just the nerve root, because we're tensioning it from both ends. Because you can get sciatic symptoms which aren't from the spine. You can further do this. Already mentioned that. So pain present in the lower back when you're going through. So if you get the pain in your lower back, it indicates that the source of pain. If pain is in the leg or lower limb, so classic symptom is in buttock area or behind knee, hamstring, feet, that's indicating it's a compression peripherally. So anywhere from past the nerve root, basically. Can also do dorsiflexion with that as well. So a couple of ways of doing this. So you can medially rotate. You medially rotate their leg first before you do anything, and then you adduct it slightly, and then you move into that straight leg raise. Okay, so that's supposed to be a little bit more sensitive. If you are getting pain further down lower limb, so below knee, that kind of thing, and you want to bias nerves further down, there's a couple of theoretical ways you can do this. So if you want to bias the tibial nerve, we do the straight leg raise as normal, but we add in dorsiflexion and eversion. So I have put an extension on there, ignore that. So eversion. Sural nerve is straight leg raise with dorsiflexion and inversion. So you're in that position and you invert, okay? Peroneal nerve, straight leg raise, medial hip rotation, plantar flexion, inversion. Okay, so you're now testing it all, so it's that way, and it's kind of moving it more medially, and you're inverting the foot, so you're stretching the outside of the ankle. Okay, so it's just about trying to bias the neural tissue at the lower end of the lower end of the spectrum of where it is, because then you can kind of, if you start to get it in dorsiflexion, right? Okay, so this is where the restriction is. So that's probably where you want to start looking at towards treatment, because it's not coming from hip, it's not coming from this, but you need to kind of get it into that position where it is symptomatic in order to treat it. Slump test, similar sort of idea. It's testing sciatic nerve. Patient seated, I tend to do it on here because I want them nice and relaxed. So I don't want them to, light touch on the floor. But if they're fully touching the floor, they're going to hold themselves up, which I found doesn't give a very good response. So I tend to use my treatment couch. So first thing we do is slump down I always say to them as if you're trying to look at your belt. So just relax in the chair and slump down. So you're flexing your lower back and you're flexing your thoracic spine. So sitting in what people think is the rubbish posture to sit at a desk. If they don't get any symptoms there, we move on to the next part. So chin to chest. So kind of get chin to chest. So that's now everything from there, theoretically down to lumbar spine under tension. Get them to actively extend their knee as far as they can and let you know if they get any of their symptoms throughout. If they can fully straighten their leg with no symptoms, you can get them to dorsiflex. So then now it's technically and theoretically fully tension from both ends. They still don't get any tension there. You can add overpressure. I tend to start with head end. So a little bit of cervical overpressure, a little bit of dorsiflexion overpressure. If they get it with either of those and you release off cervical spine, indicating that it's a positive neural tension, be aware though that it's quite easy to, if you're forcing it, you're probably going to get a positive response. You're looking for their symptoms, not just causing them pain. That's the thing with this, because if people have got tight hamstrings, it's going to hurt in the hamstrings. If they've got a bad back, this is quite possibly going to hurt their back in this position. You're looking for a reproduction of their symptoms, not just you forcing a discomfort on them. Okay, so on to pro knee bend. So this is more femoral kind of nerve, so the anterior and flexor complex. So lay them prone on the couch. So once again, I get them to do this themselves first, just so I can gauge what their range is before I start forcing it into range that they don't like. So I always stabilize the pelvis first anyway, because I want to see, because what you'll get if somebody's got tight hip flexors, they'll move and their hips will come up off the bed. So we don't want that, because that will release the tension off from a spinal level. So a little bit of pressure just above the ilium, just to he's not doing it on the picture, it's rubbish. So push down onto there and get them to actively bend their knee as far as they can. And once again, if they get their symptoms there, you may not want to do it yourself because you've already reproduced their symptoms with that movement. If they can do that and they can get to a decent end range, you can then apply a little bit of overpressure into the knee flexion. So you're now stretching kind of the knee and the quadriceps a little bit more. Be aware if somebody is tight in their quads, it may just be they've got tight quads. If they don't get any symptoms with that, you can then passively extend their hip as well. The way I tend to do this is I will be facing, I will stabilize with this hand, I will lean in, so their foot will be here, their head is away from me, and I will lean in with my hand underneath their knee, and while stabilizing, I will lift their knee and their thigh off the bed in that position. Because if anything goes wrong, I'll just leave go and they're fine. And like we said, we're looking for their symptomatic response, not just stretching quadriceps and hip flexors. So we're looking for those keywords, that shooting pain, that burning pain, that pins and needles, that kind of sensation. That's what we're looking for. Okay, Tinel's test. So Tinel's test can be pretty much done on anywhere really that you can find a superficial nerve. So some of the common ones, I've kind of put a couple of pictures on to try and illustrate on there. So what we're doing is tapping lightly on the superficial aspect of the nerve to try and bring on their neurological response, whether that be pins, needles, prickly feeling, that kind of thing. So if they're getting pain and kind of prickly feeling down this side into their little finger, I go, right, is that ulnar nerve? You've done all your tests, nothing else there. So you find a little cubital part here where the ulnar nerve runs through. The one where everybody always bangs, it's the funny bone bit. And you lightly tap on that. And what will happen is, after a few seconds, if it's positive, you will start to reproduce their symptoms. Okay. We can do this in various parts of the body. So carpal tunnel, so we're looking through this bit here. Okay. Radial, so over here on the radial head, so where the radial nerve actually passes over. So if you're struggling to find a radial head, just get them pronate, supinate, and you can feel it rotating underneath your hand. And then just tap above there. You can also tap further down, so you can trace it down. You need to, I'll put a little picture on. So it comes all the way down here, through here, into thumb and fingers. So, because it depends where, because if they've only got symptoms down here, it may not be that they will get a positive test up here, but they may get a positive test down here. Tarsal tunnel on the ankle, perineal nerve, and thoracic outlet as well. So the thoracic outlet one is a little bit more, I don't tend to use this one for this, so I'll do other things for thoracic outlet. So it's a tap up here. So you may want to tension it a little bit, and you're finding through here, and you tap in over the brachial plexus to try and recreate their symptoms. There's a few other things. So I mentioned thoracic outlet syndrome there. There's a few other tests for thoracic outlet. When I was creating the slides for this, it was getting up quite high. So I didn't want to start overloading people with different injuries, because we're going to go into like specific injuries as we go through the different joints of the body. So I don't want to start going on about thoracic outlet syndrome and this. It's just about being aware of certain tests. So a couple of very quick clearing tests that you can do with people as well. Just to kind of rule out facet joints kind of issues at a spinal level. It's not an exact science on this, because if they've got pain in that side and it's muscular, you may kind of get a false positive in that as well. So it's a very quick test. So what you're aiming to do is close down the facet joints on that side that you're testing. So for the lumbar spine, lumbar quadrant or Kemp test, what you're going to do, patients sitting or seated, I tend to get them standing for this one because it's a bit more, and get them into a bit more extension. You fixate the ilium on the other side, because if they're going to be leaning this way, you don't want it lifting up. So if you're testing the right-hand side, you fixate the left ilium. And you get them to laterally flex away. So if you're testing the right, you get them to flex to the right, and then in extension. So technically, you're going back, so you're rotating backwards. If they get no discomfort, none of their symptoms, that you can apply an overpressure by either pushing down on that shoulder or bringing them closer to you. It can be quite cumbersome to do in a standing position, because obviously they are just going to lean back. So you can do it in a seated position where you will laterally flex and extend. So technically, in theory, we are closing down the joint on my right-hand side. And that would indicate more of a nerve root issue around my lumbar spine if it recreates my symptoms. Okay? And then we test good to bad. Same sort of thing you can do at cervical spine. So with the cervical spine one, always get them to do it first. Lumbar spine, always get them to do it first. This one, always get them to do it first. This one, get them seated, because they need to be, because you're going to be pushing down on. They're really tall, you're not going to be able to. So quadrant test, Sperling's test, called different things in the literature. Patient seated, exactly the same principle. We are trying to close down those joints from that nerve root. So if you're getting ridiculous pain down your right-hand side, you've gone through all that, you're not quite sure, you're getting the symptoms, you don't know whether it's peripheral or central, you kind of want to clarify if it's coming from the nerve root, the facet joints themselves. So we're in that position, we laterally flex. If they get no discomfort in that position, then we extend. If they can hold that position for a few seconds with no increase in symptoms, so I always get them to make sure they're comfortable in that position before I do anything. What we do is we apply downward pressure, so we are then directly down. So we are trying to compress these joints on the lateral side. So we're not trying to pull them over there, it goes directly down. So it's there, directly down, so you're applying a downward pressure straight on top of their head. So as if you're trying to push straight down their spine. Because if you pull back, you're just going to pull them backwards. You're not getting anything. You're literally just pulling them backwards. If you push forwards, pull laterally, you're not going to get the same effect. After those kind of things, so I've kind of gone through my dermatomes, my myotomes, my reflexes, if I've needed to go that far. If I need to, I'll use that as a bit more of a, right, okay, if I'm doing accessory movements of spine, which I don't tend to use that much anymore, so I don't find that accurate. I tend to kind of go more by movement-based assessment and what their kind of issues are movement-wise, rather than trying to decipher the exact spinal level through palpation. So, but let's say I'm testing this, and I've got a few things. So the dermatome for L5 is showing some increased sensitivity. The myotomes are weak around the L5. I might go, right, okay, let's clear L5. So you can do it that way with the quadrant, or you can go in with a passive accessory intervertebral mobilization, where you go straight down in a prone position on their back, or you can do a unilateral or a rotation. Just to kind of clarify and hammer home whether it's from that level of the spine, and that's where their discomfort is actually coming from, or whether it's more from a peripheral point of view. So a lot of information crammed into 40 minutes there. So I apologize, Catherine, if it was a little bit whirlwindy.
I was just going to ask, with the Sperling's test, how much pressure would you put on someone's head? Because I was there getting nervous.
No, I don't. You know, you need to apply an overpressure. It's literally an overpressure. It's quite difficult to say, because one thing I always kind of say to people who are learning as well is, you know, as with any test, doing it on practicing on healthy population people is very, very different to when somebody is symptomatic and in pain in front of you. If somebody's got neck pain, chances are that's going to actually cause them some pain. So it's gradual. It's literally gradual. You don't want to be pushing them through the seat. It's about applying a little bit of overpressure just to confirm what you've already kind of suspected, really. It's not about causing them absolute agony. And that's one thing to kind of bear in mind with a lot of this stuff as well, especially with like neural tension tests and stuff like that. They may feel okay at that time, but the nerve pain can have a bit of a latency. If they've got a torn muscle and you stretch that muscle, it hurts at that point. Don't get me wrong, if they've got a compression, it's going to hurt. But how many times has kind of somebody come to you and kind of go, I was doing this, and then the day after, I was having this shooting pain down my legs and stuff like that, because that pain has a latent response. So, you know, it's not happened at that specific point. So it's gradually increased over kind of 24, 48 hours. Be aware that if you do these kind of things, that you may irritate the nervous system, they may get a latent response. So the next day, they may have an increase in symptoms. So if ever I'm doing this kind of stuff, I always tell them that before I do the test and go, right, this is the kind of route I want to go down, just to confirm what is going on and how we move forward. But it may cause you increased symptoms afterwards, even if you don't feel any symptoms in here. Are we okay to continue? Because if you don't tell them that and they get up the next day and can't get out of bed, you're going to be getting a not very nice phone call. So it's always good just to pre-warn them.
Do you do this with the majority of your clients?
No, only if I feel it's necessary. Because, like I say, with a lot of this stuff, like myotomes and stuff like that, you do it anyway. So with back pain patients, so let's say it's a lower back patient. I've had a lot of them this week, to be fair. We're only on Wednesday. It depends what they're presenting with. Like, so I've had people presenting with radiating pain down the leg, but they don't have any pain in their back. So it looks like it's coming from hip. I had one the other day which was referred from the hip. As soon as we went into a hip quadrant, that was their pain straight away. As soon as I applied a little bit of overpressure onto their hip, they were getting that radiating pain into their groin and down their thigh. So I was like, right, okay, so it's not your lower back. But then we had somebody with very similar initial presentation, and it was coming from back. And it turns out, you know, I was like, right, there's something not right here when I was kind of looking and having a bit of a feel around. I have a pars defect. Didn't mention that. So, you know, it's those kind of things as well. So, and that was coming from there. So I was like, okay, but that was historic. So it's kind of, you know, so I didn't need to do all that stuff. But there's some people where I'm kind of like, oh, we've got proper neurological symptoms here. But I tend to do it in that order it's the least invasive kind of thing. Because the quadrant thing, if I do that straight away, and somebody's got a sore neck, it's just going to irritate everything. Tendon reflexes, I tend to use more of a confirmatory kind of thing. Or if I suspect there's something a little bit more serious going on. Tension tests, once again, use them towards the end. But they're quite useful tools if somebody has, because you can use similar sort of movements as an exercise, basically. You're on Rehab My Patient, aren't you?
Yeah, because I've sometimes done like MET side of things anyway, which looked similar to some of the neurological assessment side of things as well, with certain, like the legs, especially putting them into prone and stretching. Because especially I've had like people with tight hamstrings, that kind of thing. So you would test that kind of area.
Yeah. So if you're on Rehab My Patient, where's share screen? There it is. If it actually comes up. Where is it? I don't mind me sharing this, by the way. I think that's going to be it.
Yeah.
Is that it? I've got two screens running. So obviously, I mean, you can kind of use these from same sort of thing.
So I've seen the verified ones before, like flossing, that kind of thing.
Yeah. So there's a difference between flossing and tensioning. So the flossing is relax from one end, tension at one end. So if you're doing a slump, head up and dorsiflex, and then plantar flex. And so the idea is it goes tension from one end, whereas with a stretch, you're stretching, so you're trying to tension it from both ends. My screen's all gone weird. There we are, back. Stop sharing. Yeah, so there's loads of stuff on there as well. So programs like this are quite good because you can get ideas of, because the exercise can be, although I've kind of gone through some stuff there, these exercises can also be part of an assessment. It doesn't need to, it's whatever is right for that person in front of you. So they're quite a good learning point.
Yeah. I was going to ask you about the reflex hammer. Do you have to be trained to use one? I've never used one.
I'm not 100%. I would probably say you need to have been past competent to kind of assess and use stuff like this. But at the same time, same as what I've said on like some of the other sessions, it depends what your scope of practice is. If people are wanting to learn more, then, you know, get in touch with us and we can kind of point you in the right direction. But also, if you're doing it, why are you doing it? What is it you're looking for? If you only do the tests if you know what to do with the results, don't just throw everything at them for the sake of it. Because then if they go, oh, I've got a positive, you know, I've got a brisk response, what are you going to do about it? You go, oh, I don't know. You're just doing a test for the sake of doing it.
Yeah. I think the only time I've ever thought it might be neurological was when a lady her family had a history of neurological issues, and she had issues lifting her leg, putting it into full extension. She couldn't do that. I didn't have a flex hammer, so I was just doing it more on strength, putting resistance against her leg, making her push against my hand with her ankle. She couldn't do any of that. So that's when I would refer on. So I suppose I did do it without the reflex hammer, but I think I would have potentially done it just to see if it was a nerve as well.
But that's the same thing. It tends to be more of a confirmation. So like I said, I tend to paint a picture of this, which is why I put everything on one sheet. So I'll test the dermatomes and go, right, okay, there's an issue around whatever level, right? So let's say I'll go to so C5. Let's go to C5. So I've got reduced sensation around C5 on the left-hand side. Okay, so when I go to myotomes, I've got reduced strength on shoulder abduction, elbow flexion. Okay, right, that's C5, C6, depending on the literature. Yeah? Okay, right. So what's around there? What nerves are there? How far down does the pain go? And then that's where I'd start to go onto my neural tension tests, if possible, if it is, or test the reflexes of the bicep. So it's about painting a picture as you go along, rather than just kind of going, all right, well, we've got something at T1, something at C5, something, because then it's not kind of helpful. So with the tension test, for instance, I'm not going to do all of them. I'm only going to do the one I think, or one or two, which I think are applicable. Same with the reflexes. If it's around C5, C6, I'm not going to start testing lower limb. It doesn't make any sense. When you get to the lower limb, you know, do I need to test the ankle if I think it's L3, L4? You know, because it's a different level of the spine. So is it going to tell me anything, or am I just doing a reflex for the sake of doing a reflex? So it can be daunting, but it's actually not that complicated when you get your head around it. I think it is quite important aspects to do, really. Yeah. It is quite an important thing.
Yeah.
Just to be aware of it. I'm not saying everybody has to do it, but it can be very useful. It's a useful tool to have, especially if kind of you're assessing somebody and you're stumped and go, right, okay, test all the movements. You know, they can bend over, they can stand up, they can do this and do that. It's fine. But also, it can work the other way. If somebody's, if you've got a footballer who is getting pain in their right thigh, it might be, or a weakness like when they're striking, or a weakness when they're running, it might be that the problem isn't with the muscle tissue itself. It might be neurological. It doesn't necessarily have to be pain. It could be a weakness as well. So if somebody's kind of going, something just doesn't feel right, it might be that it's tracing back that nerve. So it might be a neurological weakness rather than a muscular weakness.
Yeah.
So it's not just thinking about, oh, they've got shooting pains and this, that, and the other. It's about painting the picture with other things as well, and kind of using it as investigations elsewhere. You know, there's loads of stuff we haven't touched on. You know, I use kind of vestibular stuff with people, you know, and kind of move their eyes into different positions and, you know, under different tensions of cervical extension and rotation and stuff, to see if that kind of brings on certain symptoms.
Yeah, is it Adam Coker? Paul Coker?
Yeah.
That did that eye exercise to look at the balance with the body, I think it was.
It rings a bell.
I think it was with one of Matt's podcasts.
Was it the running one? I think it was the running one, wasn't it?
May have been, yeah.
Because I seem to remember something about that, like kind of running next to things and like balance being off. So there's all sorts, you know, that's a very quick overview of kind of a, you know, within this scope of practice, because I'm trying to keep it as relevant as possible to our member base. You know, there's some people which won't get anything out of it, but there's some people who go, oh, actually, there's a few things in there. But it could go on for hours. You know, so it could be an entire series just on that alone. We could go on to like all the theory of, you know, the dermatomes and how it works, and go into the anatomy of all the nerve pathways and how it works, chemical. It would go down all that, but do we need to at this present moment?
Yeah, because I think that's what we did in, because it was part of the anatomy course on the Learn Anatomy Online, where you learn about dermatomes, and it's from when you're an embryo and where the nerves then come from. And so I've learned a little bit.
Yeah, so they do tend to go in, if you're in a certain position,
Yeah,
you go straight.
all fours kind of thing. Yeah.
So that's an all right way of remembering it, because it goes from here all the way down.
Yeah.
So kind of dermatomes, so C1, C2, even all the way down to sacral.
Yeah.
So that's a good way of doing it. So like sacral dermatomes are going to be on the back of your leg and your feet, because that's the last bit on the chain.
Yeah.
So
I definitely need to get posters of those.
I've got them on my assessment form. So I've got a tab on my assessment form that if I'm doing any, if I bring up a neurological assessment or think somebody's doing it, I'll bring that tab up and then just make a new tab for that. And the reason I've got all that stuff listed on it is because I will forget, because I'll forget what myotome hip flexion is and all stuff like that. And I'll forget what dermatomes are where. So I like to have the diagrams there, because it means I'm not kind of hunting around for something and then stabbing in the dark. So it gives me a little bit more confidence, I suppose, like when I'm doing it, because there is a lot to, especially in the heat at the moment, there's a lot to remember.
Yeah, I was going to say about because my pen stopped halfway through, so I'll be watching it back anyway to write down what you said. But I was saying about I was thinking about the form. Is there a way of having that as an attachment, or to have a look?
Yeah, I can send it across.
Yeah.
There's very, I mean, this is just one I made for me.
Yeah.
There is ones you can download already. What's it called? There's one called Asia. So the American Spinal Injury Assessment or something like that. So there's that one. There's a few different ones, but yeah, I can send this across if you want.
Yeah, just for an idea of what to look for, especially if I get someone who I potentially think might be neurological. It might come in handy. Across. Thank you.
No problem. Anything else? Any other questions you've got?
I don't think I have any. If I do, I'll message you.
I say it's an introductory part, so we're going to go on to like different parts, so it'll be incorporated throughout. So I want to kind of go through in stages rather than kind of go right, let's go into rehab. Oh, actually, we haven't done that bit of assessment, so now we have to do that assessment. So
I found it really interesting though. I found, because it does kind of work together with the other, along with the subjective anyway. You would technically then would go into the neurological. Once you know the backstory of that person, you potentially start to get an idea of what might be going on.
Yeah, and that's what it is. It's about the subjective part is the absolute key to everything. Massively the key to everything. You know, I think I said in the last chat on this, I tend to put longer in for my first session so I can delve as much as I can and get to know that person. Like the lady the other day just completely forgot to mention that she's got a pars defect at L5, you know, like, okay, maybe that's what's causing some of your symptoms right here. But, you know, going through all medical history and kind of like previous injury and stuff like that, but she got a scan on that years ago. And it wasn't until I kind of went to kind of, oh, that's a bit prominent. She went, oh yeah, I've got this. I was like, okay, there we go. So, but if anything else crops up, if you think of anything, just drop me a message. This will be uploaded to the members section of the Facebook page as well. So members section of the website, I'll say. Okay. So I can as well download, so I've got both of the presentations so far, all on one continuous document. So I can save it as a PDF and send it across to anybody who wants it as well. If anybody wants it, just drop me a message. I'm just going to keep it going as we go along, so it's just one continuous thing.
Yeah.
Thank you for coming, and thank you to people who are listening back as well, listening to me drone on for an hour, much appreciated. Enjoy the rest of your night.
Thank you.
Thanks a lot.
Thank you.